Welcome back to the episode 2 of Clinical Topic Series. And today we are going to discuss about one of the most common presentations to the emergency department, syncope. So let's start firing the questions to Lakshay. So Lakshay, what is syncope? Can you define
So
it?
for a by definition, by definition, syncope is transient loss of consciousness with loss of postural tone, with spontaneous and full recovery,
Mhm.
essentially without medical intervention. Now, I just want to go back and highlight what are the key words here. So loss of consciousness should be transient, 2-3 minutes, definitely less than 5 minutes. If you pass out for 30 minutes, that's not syncope.
Yeah.
With loss of postural tone in contrast to seizure, where people become more kind of rigid and jerky, syncope generally comes with loss of postural tone and they pass out. The recovery should be spontaneous without medical intervention, without glucose. If you get better with some glucose, that's hypoglycemia. That's
Mhm.
not syncope by definition.
Yeah.
And the recovery should be full. If it is not full, that's a stroke or that's Todd's palsy, which can be seen after a seizure. So each of these words are important in the definition. So transient loss of consciousness with loss of postural tone, spontaneous and full recovery. Generally, people tend to use the term collapse, which is not a medical term per se. And by that, they mean either seizure or syncope, but this is the kind of textbook definition of syncope.
Okay, perfect. So, how does this happen? Can you describe the pathophysiology of syncope?
So, no matter what is causing syncope,
Mhm.
whether it's your heart or your brain or your systemic hypotension,
Mhm.
whatever the cause is, the pathophysiology is essentially the same. So let's look at what maintains our consciousness. We need to have enough cerebral perfusion to both our cerebral hemispheres, or we need to, so to pass out, we need to either compromise our cerebral perfusion or we need to have issues with brainstem blood supply, which is
Mhm.
the reticular activating system, which maintains our consciousness. So anything which causes global hyperperfusion or a drop in blood pressure
Mhm.
for about more than 10 seconds,
Mhm.
that can make someone pass out. Or if you have a midbrain TIA or a midbrain stroke or a brainstem stroke,
Mhm.
yes, you can pass out because of that as well. No matter what your what's the reason behind the cause of syncope, the pathophysiology is essentially the same. So lack of cerebral perfusion is the reason,
Okay,
in short.
perfect. And when people talk about syncope, we often hear the words near syncope or pre-syncope. Are these different diagnoses or different entities? How do you describe it?
In terms of workup, it's same. Somebody
Mm-hmm.
coming with a history of near syncope and they say, I had palpitations, I was about to pass out, but I
Mm-hmm.
didn't. I got hold of something, but then I started
Mm-hmm.
feeling better.
Yeah.
They have the same, it should be given the same significance. So it's a spectrum of a disease, near syncope, syncope. And if you're unlucky enough, then you might die of this,
Mm-hmm.
whatever the cause is. So the
Yeah.
workup should be same for these two entities.
Okay, perfect. So when you talk about syncope in the emergency department, what are the never misdiagnoses that you should always think of?
So it's really important. I think your money is with the history. You need to get a thorough history with your patient. Most of the times we don't reach a diagnosis, and when we reach a diagnosis, it is made in the emergency department. The inpatient workers are not really helpful. About 50% of the time, we never reach a diagnosis. In terms of the red flags that you should always think of, so we should take a really good history to figure out if there is anything, you know, life-threatening happening, or the chance of any life-threatening pathology. So things that we should never miss, or we should always think about in anyone with syncope, is subarach.
Mm-hmm.
Subarach hemorrhage can present with syncope. In terms of your torso and chest problems, ACS can present with syncope.
Mm-hmm.
Dissection, we've talked about this in a recent
Mm-hmm.
episode. Pericardial tamponade, pulmonary embolism.
Mm-hmm.
A lot of attention has been paid in the last couple of years
Yeah.
to pulmonary embolism presenting with syncope.
Mm-hmm.
In terms of your abdomen, GI bleed can cause that
Mm-hmm.
syncope, and we should not miss that, especially in elderly people who may not appreciate the color
Yeah.
of their stools or may not give you a history of melena
Mm-hmm.
or a ruptured ectopic. So these are the big and bad ones we should never miss. Subarach, ACS, PE, aortic issues, and GI bleed, ectopic pregnancy,
Okay.
or ruptured ectopic.
All right. Perfect. One of the most common dilemmas in the emergency department when somebody complains of syncope is we always think if there was a seizure preceding it. How
Yeah.
common is presentation of syncope that is actually a seizure, and why is it important to differentiate between the two?
I think it's important because the workup is entirely different, and this can have syncope and seizure, depending on what you think is the cause of syncope, can have implications on their lifestyle, their jobs. In terms of differentiating these two, I think the key points are sometimes to be honest, it's really, really difficult, and to get collateral from somebody who witnessed the episode.
True.
That's very important.
Yeah.
Getting history of previous seizures. Somebody has had history of previous seizures, more likely to be a seizure. If somebody's got previous heart problems or NSTEMI or recent ACS, then I would err more on the side of calling it a cardiac syncope. In terms of other things from the history, if they have post-ictal confusion, now people do lose their perception of time when this happens, but just ask them to make their best guess. If there was post-ictal confusion, people with syncope, they don't really have prolonged post-ictal phase or post-ictal phase. They generally turn around within a few minutes. And with a seizure, you might get history of heavy breathing, fast breathing, frothing, and sometimes stridor, these sort of things, but prolonged post-ictal phase or any post-ictal phase more than a few minutes should point towards a seizure. Tongue bite is one, and there are ways to differentiate this. Sometimes we say central tongue bite is more suggestive of a tip of the tongue bite is more suggestive of a syncope, and lateral tongue bite is more suggestive of a seizure. There are small studies which kind of tell us about this, but it's not 100% again. So central or tip of the tongue bite may be more likely to be associated with syncope because of loss of postural tone, or lateral tongue bite more suggestive of a seizure. And again, you get collateral previous history. It's really difficult. Now I was working in ICU once, so I saw a nurse, and she was next to a patient's bedside, and she collapsed, and she had this jerky moments. I was like, oh man, she's throwing a seizure there. But then she recovered within 2 minutes. She was fine. She was walking around. So it was actually syncope. Syncope is very well known to cause these myoclonic jerks. Because of transient cerebral hypoperfusion. If they last longer than 30 seconds or a minute, now that suggests a true seizure. If somebody's fine fairly quickly, minimal, no post-ictal state, that's probably what some people call as convulsive syncope, which is sort of a confusing term. It's actually just syncope with myoclonic jerks. That's totally possible. So big ones are post-ictal confusion, tongue bite, urinary incontinence can happen in both, but I would err more on the side of seizure in terms of urinary incontinence.
Okay, fine. Perfect. So the next question is, can stroke or TIA present with syncope? Is it common?
Stroke. If somebody has stroke, their symptoms have not improved, so they don't have full recovery, then they don't meet the definition. So stroke, no. TIAs, anterior circulation TIAs, which is your carotid blood vessels, they, by theory, it is possible if you have bilateral anterior circulation TIAs at the same point, in the same second, and that will compromise blood flow to both your cerebral hemispheres. It is possible, but it'll be extremely, extremely, extremely rare. It's unlikely. You need to have a really bad day if you have both cerebral TIAs at the same time, then you pass out. Posterior circulation, which is we also call as vertebro-basilar artery insufficiency. Posterior circulation TIAs, which compromise blood flow to your midbrain and reticular activating system, which is the part of the brain which helps us in maintaining the consciousness. If you compromise blood flow to that part of your brain, yes, posterior circulation TIAs can cause syncope. But again, they do have other symptoms of posterior circulation TIAs like dizziness or diplopia or speech issues or dysarthria. So yes, posterior circulation can cause, bilateral anterior circulation can cause, but it will be extremely, exceedingly rare.
Okay, all right. So you've talked about the emphasis on history and how is it's important to find out more about the history when you assess somebody with syncope. So coming to the
Yeah.
investigations, apart from the history, how would you investigate a patient with syncope? What blood tests or other investigations would you consider in someone presenting with syncope?
But the testing in Syncope is based on what you suspect from
Mm-hmm.
history. If you suspect GI bleed, it's worth doing a full blood count and
Yeah.
renal function, seeing the urea and hemoglobin, that sort of stuff.
Mm-hmm.
If your history doesn't make you worried, I think the only test that is recommended is the ECG, electrocardiogram, to see arrhythmias, potentially in a young person. Otherwise, besides ECG, other tests are, I think the yield of finding out something useful is very, very less. There's no use of routine CT scans if
Yeah.
their neurology is normal, they don't have any focal deficits.
Yeah.
Routine blood tests, pretty useless if you are not worried from history. It's often done because of various other reasons, but if your history doesn't make you worried, the only test that we should do is ECG.
Okay.
You've got somebody coming with abdomen pain, young female passes out, totally reasonable to do a urine pregnancy test or serum pregnancy test.
Yeah.
But unless you're worried from your history, the blood tests are not useless. The only ECG is the most useful and quick, non-invasive test that I would do.
Okay, perfect. So when you were talking about the causes, you also mentioned people with ACS or PE can present with syncope. So would you
Yes,
consider doing troponin on every patient presenting with syncope, or would you consider doing a D-dimer on every patient presenting with syncope?
I would just go with my history. If my history
Hmm.
makes me feel worried about these, yes, I
Yeah.
would not do a routine D-dimer, which is a
Hmm.
non-specific
Yeah.
test, and that would just make me, go into this route of further unnecessary investigations.
Yeah. Okay.
And routine troponins, it's a bit controversial, but I would generally not do it unless my history makes me worried about ACS. With a rock solid normal ECG, somebody low risk, now well asymptomatic, I wouldn't really do troponin on them.
Okay. Other important thing, important because most people do it in the department a lot. That's something called lying and standing blood pressure to check for any postural hypotension. What is the evidence behind checking this, and how useful is it when assessing a patient with syncope?
In short, it's pretty useless unless
Mm-hmm.
unless they have symptoms. If they have orthostatic or if they have postural symptoms, if they
Mm-hmm.
say that they were dizzy when they stood up, kind of instantaneously they were dizzy,
Yeah.
that is enough to make me think of, they are volume depleted, or
Mm-hmm.
if the blood pressure dropped, if they're compromising their cerebral blood flow.
Mm-hmm.
Elderly population who are on multiple other medications, alpha blockers, beta blockers, which can
Mm-hmm.
play with their systemic vascular system, can change
Yeah.
their blood pressure, makes orthostatic blood pressure testing or lying standing or erect supine blood pressure testing very, very, very unreliable. We should make our decisions based on that. We should make
Mm-hmm.
our decisions based on orthostatic symptoms, lying
Mm-hmm.
standing symptoms rather than lying standing
Blood
numbers,
pressure.
lying standing blood pressure. Yeah,
Yeah.
so I wouldn't pay too much attention to that. I'm not too fussed even if you don't do that.
Okay, perfect. So I think we've talked about most of the things, but coming to disposition of these patients, who would need admission to the hospital and who can go home? Is there a decision-making rule or a kind of criteria to decide that?
Before I mention, I'm just gonna kind of classify briefly how syncope. I'll just put into three uh, baskets. So one would be cardiogenic syncope,
Mm-hmm.
when you are worried, uh, somebody coming with history of palpitations preceding syncope, somebody passing out, having
Mm-hmm.
syncope at rest or at exertion, or it can be a history of structural heart disease, cardiomyopathy. So that will be
Mm-hmm.
cardiac syncope. That's going to be a history at rest or at exertion without prodrome.
Yeah.
The other one will be neurogenic syncope, which is
Mm-hmm.
pretty rare as isolated syncope. Neurogenic syncope will give you other symptoms as well. And the kind of key ones to remember are migraine can cause this, subclavian steal syndrome can cause this because of subclavian stenosis. When you exercise, you compromise blood flow to your brain because you give more blood to your exercising arm muscles.
Yeah.
That can make you pass out. And the third one will be a vertebrobasilar TIA, posterior circulation TIA. These are the three big neurologic. So cardiac, neurologic will also give you other symptoms, whatever it might be. And the third one will be neurally mediated, sort of vasovagal syncope, orthostatic syncope, when you're on 25 medications or 6 blood pressure pills or diuretics, or situational syncope. I'll just throw all of them in that neurally mediated syncope, where you get good prodrome, nausea, vomiting. You feel like you're going to pass out. You know you're going to pass out, and then you pass out because of bradycardia, vagal stimulation, and hypotension. Sometimes bradycardia and hypotension both. So cardiogenic, neurogenic, vasovagal. Most people with vasovagal do fine. And most people with cardiac, they come in. And neurological, it again depends on what the story is. Going back to your question on disposition of these patients, or anybody with high risk who would come in. Now, by high risk, I mean if they've got history of sudden cardiac deaths, if they're elderly, advanced age, if they've got recent cardiac illness, specifically acute coronary syndrome, if they've got cardiomyopathy, if they've got abnormal ECG, if they've got a pacemaker, or anything else in the history that makes you feel worried. Abnormal ECG, basically anemia and pacemaker, recent cardiac issues, age, sudden deaths in family. These would be the big ones. If somebody is well, it's reasonable to discharge them after a period of observation, but the higher the ages, the more are the chances of admission. And again, admission is not really helpful in these patients. Most often we don't need a diagnosis, but if somebody is high risk enough or looks unwell, they would just come in. In terms of disposition, there are multiple clinical kind of decision rules. I think the most talked about
Canadian and San Francisco
Canadian
syncope
Yeah.
criteria.
So Canadian is now externally validated, and it's not for low risk. I wouldn't use it for somebody who's sort of straightforward low risk. I know he can go home, or good history for vasovagal. I wouldn't use it for a slam dunk straightforward admission. It's for those patients you don't know what to do. They need to stay or go home. So it's worth, if you're sending them home, it's worth documenting some sort of decision rule, because you don't know what the diagnosis is, and it's your sort of clinical assessment and supported by a clinical decision rule. So you would be in a better position to discharge the patients. Again, good worsening statement, and make sure they get followed up with their GPs if they want a 24-hour or a prolonged halter 24-hour tape or 72-hour tape or whatever.
Okay, perfect. I think we have covered most of the questions. And if you have any new questions or any doubts, please leave it in the comments box and we can try to answer in the next session. Thank you very much.
Thank you. Bye-bye.